Hello, my name is Ruben Palacios, and today we will be talking about two different topics for this exposition. First, ribavirin for chronic hepatitis E virus infection in transplant recipients. The definition: hepatitis E is a liver infection caused by hepatitis E virus. HSV is found in the stool of an infected person. It is spread when someone unknowingly ingests the virus, even in microscopic amounts. This virus has at least four different genotypes: 1, 2, 3, and 4. Genotypes 1 and 2 have been found only in humans, genotype 3 and 4 in several animals without causing any disease, and occasionally infect humans.
To our channel. Hepatitis E is RNA virus. Spread by the fecal oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged uremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use.
Applications in medicine. HSV usually is spread by the fecal oral route in developing countries where HSV genotypes 1 and 2 predominate. The most common source of HSV infection is contaminated drinking water. In developing countries, sporadic cases of HSV genotype 3 have occurred following consumption of uncut or undercooked pork and dairy meat. Consumption of shellfish was a risk factor in a recently described outbreak that occurred among cruise ship passengers. HSV genotype 4 detected in China, Taiwan, and Japan has also been associated with foodborne transmission. Ribavirin applications in medicine. Ribavirin is one of the most common recommended treatment options alone or in combination with other drugs, but the dosage and duration is not clear. It presents a lower risk of rejection in renal and cardiac transplant recipients compared to other drugs such as PEG in FMN. Different studies support the use of ribavirin in chronic hepatitis in solid organ recipients and hematological neoplasm, but relapses have been described after stopping the treatment. Symptoms. Symptoms are fever, fatigue, loss of appetite, nausea, abdominal pain, dark urine, joint pain.
Absolutely make sure to check out the course this video was taken from.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, The lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
Pros and cons. Hepatitis E usually resolves on its own without treatment. There is no specific antiviral therapy for acute hepatitis E. Physicians should offer supportive therapy. Patients are typically advised to rest, get adequate nutrition and fluids, avoid alcohol, and check with their physicians before taking any medication that can damage the liver, especially acetaminophen. Recovery warnings shouldn't be used alone to treat hepatitis C. Heart disease warning related to red blood. Don't use if you have a history of heart disease. Pregnancy warning like birth defects or the end of the pregnancy. It may cause you to have suicidal thoughts, raise your risk of pneumonia. The combination of the drugs with pertinone alpha may cause weight loss or slowed growth in children. Issue applied in Ecuador. Every year, there are an estimated of 20 million of HSV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E. Ecuador is not an endemic country for hepatitis, as in the case of Peru and Brazil. However, despite the fact that the national rate is less than 8%, it is believed that there may be people who suffer from hepatitis but have never been diagnosed because they have not sought timely medical attention.
Hepatitis E virus, referred to as HEV, is a common cause of sporadic and epidemic acute liver disease in developing countries. In the United States, sporadic cases of both imported and locally acquired HEV infections are mostly seen among adults. Incubation ranges from 15 to 60 days following exposure, with an average of 40 days. Liver enzyme elevation, as shown in blue and labeled ALT for alanine aminotransferase, usually occurs 4 to 5 weeks after exposure to HEV and persists for 3 to 13 weeks. Symptoms noted by the purple bar occur when liver enzymes are elevated. Virus excretion in stool, illustrated by the orange bar, is variable, but usually lasts from about 1 week before symptoms appear until about 1 week after they have surfaced. However, this time frame can be longer in some people. Viremia in acute self-limited infections, shown by the green bar, can be detected about 3 weeks following exposure or a week or so prior to onset of symptoms and lasts for about 2 weeks. Antibodies to HEV, both IgM anti-HEV, depicted by the pink hatch line, and IgG anti-HEV, illustrated by the black hatch line, are usually positive about 3 to 4 weeks after exposure. IgG anti-HEV persists, but IgM anti-HEV declines rapidly during early convalescence and is usually negative by 13 weeks. HEV serologic testing in persons with acute hepatitis, for which other causes have been ruled out, may be performed, especially in someone who has recently traveled to an area where HEV infection is more common.
In conclusion, ribavirin as monotherapy may be effective in treating chronic HSV infection. A 3-month course seems to be an appropriate duration for this therapy, though a longer therapy can be given to heavily immunosuppressed patients and those who still have viremia 1 month after the initiation of the therapy. The second topic for this exposition is immunotherapy in renal cell carcinoma. What is this disease? It means that the cancer has spread to the adrenal gland or has spread to distant lymph nodes or other organs. Because the adrenal gland is attached to the kidney, the cancer often is expressed there first.
So the clinical trials, are we doing them in a different?
Moving forward, nearly almost a decade, we've successfully, as Danny pointed out, extended progression-free survival, more than doubled, sometimes tripled overall survival. It's been an absolutely dramatic time for most kidney cancer patients. But having said that, where we have fallen short is that chronic therapy is required. Coming off therapy, disease progresses. Oral agents are still associated with significant, potentially life-changing side effects that change how people do. And we need to be looking for new approaches. And at this past ASCO and throughout our literature, it's very clear that we're revisiting, Jan, the role of immune-based therapy. For those of us that have given immune-based therapy for years, one recognizes that in our practices, if you ask the question, what's the most likely therapy a person received for a period of time and then had an unmaintained remission for years or decades, it's IL-2. And yes, IL-2 is difficult to give. And yes, IL-2 doesn't work in most people, but it does tell us something about biology. So the question, Jan, is are we revisiting the role of immune therapy in kidney cancer, and if so, how? And are we doing it the right way? Did we learn the right lessons from the first experience? Are we applying it in the second experience? And are the endpoints, the biomarkers that we're looking for in the patient populations, are the right populations? That's a lot on your plate, but take a stab at it.
Thank you. Yes, immunotherapy is having a resurgence of interest, no question about it. Yesterday morning, we actually had a Society of Immunotherapy of Cancer symposium to talk about different approaches. And I will talk to your specific question, which is about the new understanding of taking the brake off the immune system with checkpoint inhibitors. But I wanted to just mention one point that was made, which is still underexplored and needs further evaluation, which is the combination of stereotactic radiation with immunotherapy to get an abscopal effect on tumor. And that has not been well explored in humans, but very well documented in animals. So that's another direction that immunotherapy is going.
So let's just be clear so the audience understands. So by an abscopal effect, you mean that giving local radiation therapy to a targeted tumor could alter the antigenic expression in a way that might allow for an immunologic reaction at sites that weren't irradiated.
Correct. Correct.
And you think that whether it's a kidney cancer, obviously melanoma or other diseases, that we need to be thinking about the benefits of antigen exposure in the context of further immunotherapeutic approaches.
I do.
Okay.
And then the checkpoint inhibitors, which of course are fascinating, which is that we have a system in the immune system where we stimulate and then we can control it with regulatory T cells or with other modulation of immune expression. And now we have discovered that both anti-CTLA-4 antibodies and now most recently anti-PD-1 and anti-PD-L1 antibodies can take the brake off the immune system and allow the immune system to identify and progress against antigens that are tumor specific. And, the clinical data are very compelling. We're seeing responses not only in kidney cancer and melanoma, but even in lung cancer and prostate cancer. So it's suggesting that tumors can be more immunogenic than previously believed with the advent of a different type of modulation of the immune system.
Immunotherapy is the use of medicine to boost a person's own immune system to recognize and destroy cancer cells more effectively. Several types of immunotherapy can be used to treat kidney cancer. An important part of the immune system it is the ability to keep the cells from attacking normal cells in the body. To do this, it uses checkpoints, which are proteins or immune cells that need to be turned on or off to start an immune response. Kidney cancer cells sometimes use these checkpoints to avoid being attacked by the immune system. But these drugs target the checkpoint proteins, helping to restore the immune response against the cancer cells. Applications in medicine. There have been many advances in treating advanced kidney cancer with immunotherapy drugs known as checkpoint inhibitors. These use the body's own immune system to fight cancer. These drugs include ipilimumab and nivolumab. They are usually given into a vein intravenously. Taking these drugs together have been shown to work well as first-line treatment for advanced kidney cancer. In people with advanced kidney cancer, the previously treated with a tyrosine kinase inhibitor, nivolumab has been shown to work well as second-line treatment. Clinical trials are testing checkpoint immunotherapy at many stages of kidney cancer after surgery as the first treatment for advanced kidney cancer, and together with existing kidney cancer drugs, such as a combination with TKIs. Clinical trials are also testing new types of immunotherapy and target therapy drugs.
I think when we look at the treatment for advanced renal cell carcinoma, it certainly has changed significantly. In past several years, renal cell carcinoma doesn't respond to traditional cytotoxic chemotherapy, and we had the advent of the first target therapies with the VEGF TKIs, over now, I guess, close to 15 years ago, that really showed an improvement in progression-free survival. And then for a while, that was the mainstay. And then, back in 2017, we saw the first data showing that immunotherapy has a role in the frontline treatment with the presentation of that for Nivo and Ipi showing improvement in overall survival, anemia poor risk versus sunitinib. And then since then, we've had other VEGF IO combinations with both axitinib pembrolizumab and axitinib avelumab approved by regulatory agencies, given, in the case of axi-pembro, improvement in overall survival and progression-free survival versus sunitinib in all patients in the cannabis group, and with axi-avelumab improvement in progression-free survival. And so, there's a wide variety of options to offer our patients now. With, I think, TKI monotherapy being used less and less, given this data, and both, Nivo, Ipi, Axi, Pembro really becoming a new standard of care, given the overall survival benefit of patients with renal cell carcinoma.
Pros and cons. Pros. The target of these drugs is the PD-1, a protein on immune system cells called T cells that normally help keep these cells from attacking other cells in the body. By blocking PD-1, these drugs boost the immune response against kidney cancer cells. They can often shrink some tumors or slow their growth. Pembrolizumab can be used in the treatment for people with advanced kidney cancer. Nivolumab can be used for people whose advanced kidney cancer starts growing again after targeted drug treatment and has shown to help people live longer. For patients with intermediate or poor risk advanced kidney cancer who have not received any treatment, nivolumab can be given with ipilimumab for four doses, followed by nivolumab alone. Cons. Side effects of PD-1 inhibitors can include fatigue, cold, nausea, itching, skin rash, loss of appetite, constipation, joint pain, and diarrhea. The most common side effects of the combination of avelumab with axitinib include fatigue, diarrhea, high blood pressure, skin rash, or blistering, cough, shortness of breath, or abdominal pain.
I will present a study called RADVAX. So radiation vaccination, if you will. It's a small study that asks the question, do we see something about this mysterious romantic abscopal effect in kidney cancer? So the question is, if we apply definitive radiation, high dose stereotactic radiation to a tumor site, can we potentially increase the response rate to potent immunotherapy? At the time when we designed the study, we took the most potent immunotherapy that there was, nivolumab/ipilimumab, a PD-1 and CTLA-4 inhibitor, and then really applied 5 fractions of high dose, very precise radiation to 1 to 2 tumor sites. The question is, do we potentially see an increased response rate as a signal that maybe that approach may improve the benefit from immunotherapy? It's a small study, was supported by BMS with free drug, and more importantly, was supported by philanthropy from patients actually to be able to pull that study off. 25 patients, we did see an increase in response rates. We do see a signal that this approach may actually increase and benefit the immune response in that context. It will be opposed to data from an Italian study that used a little bit less radiation and just PD-1 monotherapy, where they did not see an increase in response rate. So maybe this particular combination, maybe the presence of the CTLA-4 inhibitor, maybe the intensity of the radiation, maybe some of these factors are important to do it. It's a small study, and it's all the caveats of a small single institution study. And there needs to be some complementary data generated to confirm the findings. One of the ways we're moving this forward with is that we are going to do PD-L1 PET imaging of patients. It's a very novel way to light up all the tumors in the patients and then see how inflamed are those. Then potentially pick out the ones that are the coldest, less inflamed tumors, aim the radiation to those particular disease sites, and see if that in particular will boost the immune response to otherwise very difficult to treat kidney cancer tumors.
Issue applying Ecuador. Worldwide, renal cell cancer corresponds to an incidence of 2.4 in both cases, a mortality of 1.7%, and its prevalence at 5 years is 2.8%. Renal cell cancer accounts for 3 to 5% of neoplasm in adults. In Ecuador, according to data from the National Institute of Statistics and Census, renal cancer is more frequent in men with 2.5% and in women with 0.9%. This disease is the most common type of kidney cancer in adults and occurs most often in men between the age of 50 and 70. The exact cause is not known. The following factors may increase the risk of kidney cancer: smoking, obesity, dialysis treatment, family history of the disease, high blood pressure, Horshaw's kidney, long-term use of certain medications, Walter's disease, and big hot tub syndrome. In conclusion, immunotherapy has changed in a great way the treatment of the RCC. The use of immunotherapy using cultural cells such as DCS to treat large numbers of patients because of the complexity of the immune response involved. It is difficult to evaluate the efficacy of immunotherapy compared with other treatment. However, it is clear that the immune system plays a significant role in the control of the tumors. Continuing analysis of the mechanisms involved in tumor immunity and the development of new immunotherapies are vital. Thank you.